Jason. Hello. There's no time for today. It's very lucky, but come here on Sunday. Okay. Today we are so happy to invite Dennis to come over again to share his experience in spinal pain indication. Okay. So because the time is very limited tonight, so we start. Okay. Okay. Let's give a big hand to the.
Thank you very much, and thank you, Jason and Richard, for inviting me again. And I always succeed to bring a typhoon with me when I come over here. So, but we'll be flying out tomorrow again, just before they close the airport. So hopefully we'll get away. So we have limited time here tonight. So I'm going to try and make this here as practical as possible. So I'm going to go through some theory which is designed especially for this device here. And then I'm going to show some cases. And then I'll do some practical demonstration on the spine and in the pelvic girdle. I've been working with shockwaves for the last 17 years now, focus shockwaves, and I've been working with all the devices on the market. And what I'm going to talk about today is this device here, the Piezowave 2. So, a short introduction with some theory, and then we go into some practical sessions, and then we end off with some questions. If you have any questions on the way, please raise your hand and take the opportunity of asking me these questions if you have any. So as you probably know, there are several technologies available for producing shockwaves. And what we're talking about today is this piezoelectric principle, which is the newest ones, and the most powerful one when you want to treat deep lesions around the spine and the pelvic girdle. So even though there's been a lot of research on shockwave therapy, focused shockwave therapy during the years, we still don't exactly know how shockwaves work in the body. We know a lot of the parameters which they produce, but the full truth we don't know. But what we have to concentrate about is these three values. The pressure that the device can produce, what we call the energy flux density, which is a value for estimating the energy that we actually use in the tissues, and then how much total energy we apply to the tissues. So the pressure that the machine can produce is limited by the machine. The energy flux density is an indication on this machine from 0 to 20, which actually tells you how much energy you put into the tissues. And the total amount of energy is the amount of shots that you actually deliver to the patient. There's a lot of different devices in the market here, and they all differ in the way the machine is producing the energy, how flexible it is, and how the pressure waves are distributed while you give these shock waves. What's a common denominator for these machines is that they produce a focal zone of shock wave. And that's actually what's important when you treat the patients. That's how the focal zone looks like, which actually goes into the tissues that you treat. And there's a lot of difference between the sizes of these shockwaves zones between the machines. And just to confuse you even more, in these zones here, the energy is highest in the middle and weakest in the outer skirts. That's especially true from the old devices. With the new devices here from Wolf, the energy is very, very high in the total area of the shockwave focal zone. That means that the energy that you deliver to the tissues are much higher in a concentrated space. And that's very important when we treat sensible tissues around the spine and around the hip, because we can actually use this machine to get into very small areas without affecting others. And as you know, around the spine, there's a spinal cord, spinal nerves. We don't want to injure them. Around the hip region, we have large vessels, nerves, and arteries, which we don't want to affect either. And we have sensible joint tissue too, which can also be a contraindication to treat. So when we talk about this energy flux density, it's described in millijoules per square millimeters. That's how much energy you can put into these tissues. But it's only a number. So if one machine can produce 0.5 millijoules per millimeter, it might not be the same as another machine which on the paper produces less. So with these machines, because the energy is so homogeneous and concentrated in the whole beam, we don't need as high energy values on these machines compared to the competitors, which I'll demonstrate later here. So don't rely very much on what the numbers say. You have to rely on what the patients feel when you treat them, and if you produce the pain that they're complaining about. That's the main thing. That's psychosocial feedback from the patients. So you have to communicate with them while you're treating them. So this is actually how it looks on a graph. This is a Shockwave device. Here you see the focal zone here. In other competitors, the amount of energy is highest here. With these devices here, we have a high energy in the whole area of the focal beam. Another thing which is very important is that these shock waves, they're a physical phenomenon. They interact with everything they come in contact with. So if you treat a superficial structure, most of energy will hit the structure and go into the structure. When you go deeper into the tissues, 2, 3, 4, 5 centimeters, a lot of the energy will dissipate and refract on the way. So when you treat deeper structures, you have to increase the energy levels, despite what the manual tells you. And when you come in contact with bony tissue, the shock wave stops. It cannot penetrate bony tissue. So, and we find a lot of bones around the spine and around the hip. So we have to take that into consideration when we actually start treating lesions there. So as I told you, what these machines do is they work at a higher pressure level than other competitors. And when you look at a shock wave, it looks like this. It's a very short rise time with a high pressure, which collapses very fast and produces a negative tensile phase. So this phase here, the positive phase, with this device, rises very quickly compared to the competitors and rises higher and falls quicker. So you get a much faster shock wave. And the patient can actually experience that when you treat them with these devices compared to some older devices. So actually this shock wave shocks the tissue more than the competitors. And that's what you have to take into consideration when the patient is lying there, because they can feel certain lesions much more than if they used another machine. The other advantage with this machine here is that we have some different headpieces. We have these known ones, the round ones. This here is what's called a double layer. It's the newest device. It consists of 2 layers of ceramics, which actually produce a larger focal zone and more energy than the previous headpieces. And then we have this one, the new one. Have you seen the linear device before? It's a new way of producing shock waves, where we have not a cigar form shock wave, but a linear shock wave. And it actually produces a shockwave and covers a much larger area than the other devices. So at some areas, anatomical areas in the body, it's very good to use this device, whereas we want to go deeper in the body and more precise, we use this headpiece here. How many of you have experience working with shockwaves? Most of you? Yeah? And how many have worked with the Wolf machines? A few of you? Yeah? Okay. So another thing is that we use these gel pads we put on, which just sits on here, to actually concentrate the focal zone as deep as we want to in the tissues. So we know that these shock waves, when they hit our tissues, then they produce a lot of action. They cause like molecular changes and tissue changes by stressing the tissues, and they also interact with our nervous system to modulate pain and to alter neurological feedback from the body to the brain. So all these factors you probably know. We have a lot of tissue changes going on in sick tissues, which starts the regeneration and neurovascularization. But, very, very important, we have here at the end, we have a stimulation of neurons and nerve endings in the tissues which are actually producing the pain. Why are patients coming into our clinics? Why? Because they feel good? No, because they have pain. So what we have to do as practitioners is to focus on the pain. We want to get the pain away as fast as possible. We don't want to tell a story to the patient that this tendon is sick and in 3 months' time it will be much better if you give you shock waves. The patient just wants to get out of pain. So how do we use these devices to get the patient out of pain as fast as possible? That's what I've tried to work with for the last years. So that's the theory that I'm going to explain to you and show you in practice how you can actually do that. We were earlier today on a clinic visit in Hong Kong with a chiropractor who had the older device here and who just invested in an ultrasound scanner so he could actually see what he was treating. And we were discussing a patient, a nurse at the clinic, who had a tennis elbow. And he tried to treat her many times, 10, 20 times with this shockwave device, but she didn't get any better. And he just used the manual and did what the manual said. But when you start working with equipment, you find out that some areas in the body, tendons, don't respond as other areas. The tennis elbow can sometimes be quite hard to treat, and it needs another energy level and another treatment approach to get successful. And that's the clinical points I'm going to tell you today. It's not what you find in the manual, but it's what we experience with all these chronic tendinopathies and back pain and hip problems here again. So the treatment protocol is going to differ from area to area. We don't know why. We don't know why, for example, a golfer's elbow responds very poorly to shockwave compared to an Achilles tendon. They're both tendons, they look different, but there's different disease processes going on in them. So they have to be treated in another way. What I found when I started treating with shockwaves, I've always been ultrasound scanning. I'd scan the tissues before I treat, and I try to scan them a month, and 2, and 3, and 6 months afterwards to see if there's any change. And what you find is that when you start treating with shockwaves, sometimes after 4 or 5 treatments, the patient will be pain-free, but when I scan the tendon, it will look exactly the same. It would look just as sick as it did to start out with. And when we look at the research on this area, when we MRI scan and ultrasound tendons, it takes half a year, 1 to 2 years for the tendon to normalize, but the pain is gone much faster than that. So what does that tell us? What does that tell you? It tells me that there is a pain perception which has gone wild. There's been some sensitization in these tissues, and we are probably not only treating some regeneration of the tissues, we are also treating the nervous system to lower the pain. So we started out trying to see how can we actually manipulate with the nervous system by using this equipment as fast as possible, so the patient gets pain-free and they can start some rehabilitation. So studies have also shown that with sick tendon tissues and muscular problems and ligament problems, we see an ingrowth of nerve fibers, which guides the immune system to heal up our tissues. What happens in a chronic inflammation is that normally these nerve endings go in and help the immune system to build up the tissues, and when they actually heal, they retract again. But with these chronic tendinopathies, these tendons stay in the tendon. And that's why a tendon hurts when you press on it, and it hurts when you actually make a movement where you affect the tendon. By giving shock waves, we see that these nerves actually die and diminish in size and in number. But they do so with different kind of energy levels. There's a lot of literature here which tells us how, or we think, that shock waves affect the nervous system and neurons and the pain pathways that we treat. They're very diffuse, but they show that we not only affect these nerve endings and the chemical environment in the diseased tissues, but we also affect the central nervous system at a spinal and a cerebral level. They've done many studies where they've been giving shock waves to people who were anesthetized, so they couldn't feel the treatment. And when you do that to patients, they respond much poorlier than if they feel the pain while you treat them. So we know there's some kind of central sensitization going on when we treat these patients. So it's very important that the patient feels pain when you treat them. That's one aspect of this here, but it still has to be tolerable. And what is mostly, probably the most important fact here is that when you treat a patient with shock waves, you have to be able to diminish the pain a little bit while you treat them. Does that make sense? Have you tried to put on a shock wave and the pain is very high to start with, but after a minute or two the pain dissipates a little bit and gets more bearable? That's what you have to wait for when you treat these patients, because that's what's causing central desensitization at a spinal and a cortical level. And that's the key to getting the patient out of pain fast. So all these pathways which produce the pain, we know a fraction of them, but we cannot explain them all yet, but I don't care. We just have to find a way where we can get the pain or the patient out of pain as fast as possible. And then we have to use all kinds of means to do that. And that means that we have to experiment with the device. And we have to experiment for each and every region in the body. So, I urge you, when you use the shock wave, you have to use it as a hammer. You have to get rid of the pain by overstimulating the patient's pain. That's the way you get them out of pain the fastest way. We've seen that for many years in nerve pain patients, like disc prolapse patients who have sharp shooting pains into the arms or legs. If you do not cover them properly in painkillers to start with, pain medicine, you get a sensitization of the pain. So it's very, very important that you bring the pain levels down as fast as possible so you don't increase the pain threshold of the whole body of the nervous system. So what we all know from the books is that shock waves actually causes tissue repair, but what's most important for you and your patients is that you want to get them out of pain as fast as possible. And the more innervated the tissues are by nerves, the faster they respond. That looks to be the secret behind why some tendons respond better than others. The more nerve supply which actually goes into these tendons, the faster they respond. The less innervated the area is by nerves, the better they respond. And that is very true around the spine. Because, let's say, a square inch in the spine is innervated by 300 times more nerves than the rest of the body. So when you actually interact with tissues around the spine, you get very dramatic results, and you get them immediately if you do it correctly. Even with chronic pain patients who have pain for years, after a treatment or two, if you do it correctly, they can feel a difference. So what does all the research shows us? It shows us that shock waves are quite safe in the body, and most of the research has been done on tendon tissue. And we know within certain limits, 0.1 to 0.35 millijoules per square millimeter, if we use those dosages, we get quite good results. But what research also shows us is that at some areas we have to use higher doses than with other areas. So what does the research tell us about pain around the spine and deep-seated pain in the pelvis? We are very limited there. We have very, very few clinical studies. Only 10, 15 studies we have done now. Small studies with small cohorts. But all of them show promising results. I haven't read one study yet around the spine which didn't show a positive response from the patients. And we had several studies done out here in Korea and in China in big hospital settings. And they had a control group where they did exercise and pain therapy. And the Shockwave group showed significant improvement in these chronic spinal cases. There's also been studies done on some degenerative changes in the body, like osteoarthritis in the spine, with calcifications and facet degeneration, and they also showed good results. The problem with these studies is that they vary in the way they treated the patients, and how many treatments they got, and what energy levels they received. And they all were done with different equipment. So we had to start all over and see how this equipment here works around the spine. So I just put them into your notes so you can read them back home here. We know that shock waves work very well at muscular problems. The most of the work has been done on hypertonic muscles in the neck and shoulder region and in the hip region, and on trigger points. And they all show very good response in the body. A few treatments and you can actually get rid of a trigger point, and you can cause normal tone in the muscles around the tissues. The good thing by using this equipment here is that you don't need an MRI or X-ray or ultrasound. You can actually, just by doing a proper examination and communicating with your patient, you can actually apply this at day one without causing any problem, as long as you know your anatomy. We don't use them on these things: infections, tumors, stay away from that. No lung or brain tissue, no bowels. Large nerves, it's not very comfortable to receive shockwave therapy on. Large vessels, arteries, we don't want to come into the window because we don't know the side effects of it. So the literature shows us about what these different doses actually produce. Low doses produce new blood supply or new blood growth or blood vessel growth in the tissues. The medium, moderate intensity treatment between 0.2 and 0.5 both cause cell deterioration and pain modulation, while the higher doses actually we don't need. They're not necessary with this equipment here. So we want to stay in this level here. These machines can cause higher doses, and you can use them if you treat stress fractures, pseudofractures, cortex, cartilage injuries. You can actually also use that. But that's not going to be covered today here. So we have to use about 0.2 to 0.4 millijoules when we treat around the spine. And often you have to maybe use a little bit more because we are working about 3 or 4 centimeters down the tissues, and a lot of the energy will actually be dissipated or refracted by the bony tissue. So it's important that you actually don't go too deep or too shallow. So you have to know what kind of gel pad you use for each patient to be successful. And before we go into it, think about it. Shockwave is only one part of treatment. Sometimes, if they have very acute stages, they might be in need for pain medication and injectional therapy before you start shockwaves. So if in doubt, refer for an MRI or an ultrasound to see which state the lesion is in. If you're not sure about what condition the tissue is in, there might be a large rupture, don't start treating. Refer for radiographic evaluation before you start. I always tell my patients, normally with tendon diseases, that they have to rest for the first 4 weeks after treatment. No exercise. After that, we initiate it. With the spine, it's different. The spine, you actually have to initiate exercises after the first or second treatment. That's very important. And I'll come back to that, why that is so. I'll just go through here. Always start with a low frequency, so the patient adapts to the shockwave. They haven't experienced the pain before. Increase the frequency and increase the energy. And I always ask the patient to think about pain within the limits of 0 to 10, where 0 is no pain and 10 is the worst possible. 7, 6 or 7 they can adapt to. Higher than that is no good. So when my patients come into me and they have to have shockwave therapy the first time, I tell them we're not going to talk words anymore, we're going to talk numbers. So you communicate with me. So when they're lying there, they're saying 4, 5, 6, 8. Then I turn it down again. So I always have to communicate with the patient to see what kind of pain area they are in. The second most important thing is that when you give the treatment, you have to reproduce the pain that the patient is complaining about. Because with a shockwave therapy device, you can create all kinds of havoc on the body if you want to, but you only have to treat what is important, and that's the patient's known pain. Normally with healthy tissue, you don't feel anything when you put the shockwave device on. But if you have degenerative tissue, like me, my old age here, my tendons are not as an 18-year-old. So if you put it on, even though I don't have any pain in my shoulder, if you put it on a degenerative tendon, I might feel some pain, but it's not relevant. So be sure that you're actually looking for that. You have to reproduce the patient's known pain. Around the spine, I stay in the same spot at least for 300 shots, up till 1,000 shots. Normally 300 to 500 shots is enough. And I always wait until the pain dissipates, gets less. That's very important, especially around the spine. Around the body we treat tendons. Some of you may also be treating trigger points and muscular points. It's a little bit different around the spine, because our knowledge around what is producing pain is different around the spine and the hip than it is for tendon disease here. I'll come into that more detail here. So this is the smallest device that we have. This is the biggest pinpoint one, which is this one here, which I use myself. And I've used the two former machines, but this device here is the most powerful device that you can use around the spine, and the most precise you can use too. This device produces a cigar-shaped focal zone, which is about 2 to 1 centimeter, depending on how high you turn up the energy, and about 5 to 6 millimeters in diameter. So it's very precise. When you use these gel pads, you can put them into exactly the area that you want to treat without it causing scatter radiation to the rest of the body. We used our other devices around the spine, but because the focal zone is so big and the energy fluctuates within the focal zone, it doesn't cause the same responses around the spine. So this is the line of choice for you if you want to treat spinal problems and deep-seated hip problems. We can turn up the energy from 0 to 20, and you can see here what the different numbers actually point to. So level 10 is actually 0.266 millijoules per square millimeter. And when I treat with this device around the spine, I always start around here at a high level, because that's not the actual dose which actually is going into the tissue. It dissipates on the way down. So you have to use higher doses around the pelvic girdle and around the spine. This linear device you can also use in the cervical region and some stages in the hip region too, which I'll show you. With people who are not too big, women, you can use them in the neck area. Around the trochanter, it's very, very good too, which I will demonstrate for you in a little while. The good thing about this area here, the linear shape, is that we have a large zone of shockwave here. Very large zone. It's about 50 times as big as this device here. So you treat a big area. So a big area is sometimes very good to treat when we're talking about the hip, the insertionals of the tendons, and the friction of the iliotibial tract. It could be a good idea to use it there. I always tissue mark my patients, because around the spine you go deep. So when you sit on top of the skin with this device here and you press it down, because you're going about 4 or 5 centimeters down, if I angle it just a little bit or slip off, I will hit a total different area. And if you want to modulate pain and recreate another muscular tension, you have to be in the same spot the whole time until the pain starts dissipating. That's very important. Where are we going here? So trigger points you know all about. I don't want to go into that. Taut bond, tender nodule. When you press them, the patient can recognize the pain that they're complaining about. And is often referred. When we go into the nitty-gritty now here, before we go into the practical session, we have to do a full diagnostic workup. So you do your inspection, you do active passive range of motion, because it tells us a lot about spinal pain. When you have flexion pain, pain on sitting, pain on bending forwards, coughing, sneezing, it nearly always involves a disc problem at some stage. It might be a little disc overload, a protrusion, or a prolapse. Think about that. If you have a rotational problem, extension and rotation, it is often more a sign of facet joint involvement. Often, not always. But that should give you a sign just by actually doing some basic examination on your patient. I will also introduce you to just some very, very simple palpation of the spinal joints, which might give you an understanding of where the problem is and if you can reproduce the pain. We know the foraminal and axial compression test of the neck to see if that produces any pain or foraminal compression. Urology, always check that. Most chronic pain patients have had some neurological problems and have succumbed a little bit, but still have residual problems, so there's no contraindication for treating them at all. Do a full physical examination just to be sure, and if you have some tissues that you are suspect of how they are working, and if you suspect any other pathology, do your radiographic examinations too. The pain pattern is always a very good storyteller about where the pain is coming from. Is it dermatonal pain? Then we are actually talking about spinal nerves. Is it more diffuse referred pain? Then we are talking about joints, muscles, ligaments, joint capsules. And each of them, those structures, have their own referral patterns, which you have to learn. Takes time. Test the spinal motion. Do compressional tests over the joints in the pelvis, hip joint, sacroiliac joint. They can also produce pain too and can be co-involved too. Percuss the spine and ribs just to rule out any compressional fractures or anything else pathology in the bony tissues. So this is like a typical referred pain for the facet joints. You can see it's not very in the periphery. It stays around the stays around the back and the pelvic region, but doesn't radiate into the fingers or into the toes. That's the thing with spinal nerve pain, dermatomes. It refers distally, all the way into your extremities. And just to confuse you even more, ligaments, joint capsules actually refer in a sclerotonal pattern, which is the same for lesions in the upper part of the back and the lower part of the back. They refer to the same place. So it gives us a great mixture of pain. So typically, chronic pain patients with neck from the neck and the back, they have a diffuse pain pattern. It's not very specific. And why is that? That's because the body has adapted to pain. So several structures are not working correctly. What happens to your patient when they come in, or what happens to your patients when they come in with a lumbar disc prolapse? What do they complain of? Sciatica. Shooting pains into the leg, shooting pains in the back. But what else? They don't move normally, do they? No. The body tries to protect the damaged tissues by tensing up the muscles around the joints. So we get a compensatory pattern where they, typically antalgic, stand to one side, can do certain movements, and that pattern continues as long as the patient perceives pain. So if this pain doesn't go away within a few months, it alters the tension and the joint movement around these structures. And what do we know about research about spinal pain? It's very complex, isn't it? Very, very complex. So we can deal with the concept of if the disc is pressing on a nerve, it's causing pain. But why does this disc not heal up again? We all know if I take an MRI scan of you sitting in here, 30 to 40% of you will have a disc prolapse in your back. But it's not symptomatic. So it's a living process. They degenerate over time, go in and out, and some just don't, actually. So during the last 15 years, they've been doing a lot of electromyographic studies around the spine, and we find that what's the common denominator with these chronic pain patients is that they have hypertonic deep paraspinal muscles, which do not function properly, and which produce a lot of pain. We have trigger points, or nerve pain from these paraspinal muscles. They don't function, and they actually serve for the movement in the spine. If they don't function correctly, they don't distribute loads properly into the discs, into the facet joints, and then you get irritations of those structures. That's why exercise therapy has been such a big thing. If we can get these muscles activated again, often these large injuries, disc problems, they can actually heal them up themselves, so they don't need operation. But some don't respond, and they become chronic spinal pain patients. They come into your office and ask them to help you. They try different kind of therapies. They try pain therapy, medication. Some have even tried surgery. Some have tried exercise regimes, but they do not seem to work. And if you, as a chiropractor like me, have been treating them, pressing on the muscles, manipulating them, stretching them, giving them advice and giving them exercises, but they still don't respond. They keep on having the wrong loading. So the key is to normalize the nervous system supply to these deep muscles. Let me continue. Just to show you the different anatomical levels before we go into the treatment. The spine looks different from above than from below. So we see at the cervical level, we have the interspinous ligaments nuchae here. We have the facet joints, which are sagittally orientated. So potentially, we can actually treat this area here. We don't want to go into the spinal canal, and we don't want to go into the spinal nerve roots coming out here. If you do that, the patient will jump off the bench. I've done it several times. They'll have a sharp shooting pain into the nerve root, which produces pain into the periphery. So, just behind here, we have what we want to address. The facet joint and the deep paraspinal muscles. The intervertebral disc is not very heavily innervated by nerves. It's a passive thing. It doesn't give the big feedback to the nervous system. All the feedback to movement and pain modulation comes from the facet joints and the deep paraspinal muscles. We can't get to them with our fingers. It's impossible. They lie 4 or 5 centimeters down, so you might just go through other muscles and try to stimulate them, but often that's not enough. So we have to find another way, and that's where this focal device comes into actually play. So we want to reach these muscles here. They're responsible for spinal health. They're responsible for proper loading of your disc and your facet joints. If you normalize those muscles, you will, most cases, actually see that all the disc and facet joint problems disappear by themselves. This is how it looks in an actual plane. This is a cervical spine. As you can see, all the structures that you want to keep away from are quite far away. So we can address this whole area here by actually angling the device, Shockwave device, shooting at a 45-degree angle in here and in here. We don't want to come out here and not in here. Luckily, the bony structures protect the spinal cord, so you have to be very good at hitting the spinal cord if you want to. Another thing is, you have to localize the area which is producing pain. And luckily for us, most spinal problems, chronic problems, exist in the low cervical spine and in the low lumbar spine. Due to anatomical stresses, we see degeneration of those structures, lower cervical spine and lumbar spine, and that's nearly where we see 90 to 95% of all chronic lesions in the spine. So they're quite easy to find. If you want to localize them, you can do it with the patient lying down on the back, so they relax, and you can go in and feel upon the muscles and actually move the joints And when you hit the joints which are producing the pain, the patient will tell you. And normally it's only 1 or 2 or 3 segments that you have to treat. This is just an ultrasound scan of how a spine looks like from the posterior. This is the skin tissue up here. This is the spinal process lying here. And down here we have the lamina. So when I measured it out, you can see there's about 3 centimeters down there in a young woman. So we can actually work to that depth. We don't want to work deeper, and we don't want to work more superficial. So with most women, you use a gel pad 20 millimeters. With very large women, you use maybe 30 millimeters. With men, you use 30 millimeters. With very large men, you use 40 millimeters. That is nearly always the truth when I measure things. Here's a longitudinal scan of the ultrasound scan of the spine. This is superficial fatty tissue. Here we see the muscles, and down here we see the facet joints. The nerve roots are coming out here. And this is centimeters here. We are about 2 to 3 centimeters down before we get into the facet joints. So optimally, you want to stimulate the deep paraspinal muscles and the joint capsule of the facet. That's where you get the most neurological feedback. Skin marking, you can skin mark the spinous processes or the transverse processes so you don't glide off during treatment. Most often I use this device here, and only with very slim women I use the other linear device here. So one thing, when we see chronic spinal patients, most of them have been in MRI scan, and what you see with them, just after a month or 2, you see deep fat infiltration in the deep paraspinal muscles. So muscle tissue is being replaced by fatty tissue. And is fat very strong contractor? No, it's not. So just after a month with a nerve root compression, you see spinal fatty infiltration in those muscles. They simply become hypertonic and they become weak. When they become weak, they tense up and they straighten out the spine and cause wrong loading on the intervertebral discs and on the facet joints. So they don't have a chance to heal up if you can't activate them again. So we have to alter this. This is an MRI of one of my patients. This is the intervertebral disc. Here we see the neural canal. Here we see a big fat nerve root. Here it's all dissipated. It's being pressed upon by this disc prolapse, which is massive. This here is muscle tissue. This here is fatty infiltration. That's fat. It looks white on MRI scan. Here we see it from the side. The intervertebral disc lying in here. Here we see a all dehydrated disc with a massive protrusion. And what we see is compression of the spinal cord. Within a month or 2, things start looking like this here. It's quite impressive. Here we have normal deep outer layers of spinal muscles. Here we have the deep paraspinal. Look where the fatty infiltration takes place. It starts at the deep paraspinal muscles, which we are most important for us to become pain-free and offload our body. That's just after a month. The lucky thing is that it's totally reversible. When we start treating them and activating these muscles, after a month or 2, the fatty infiltration actually goes away again. The lumbar spine looks a bit different. We have slightly orientated facet joints. So our angle of line, we want to treat the facet joint is going to be a little bit different. Still, we have even more place, even in the thoracic spine, there's lots of place. The lung tissue lies much deeper than the muscles that we want to treat. So as long as you angle your beam this way, you won't get near the lung tissue. And the lumbar spine, we are working quite deep, 3 to 5 centimeters down, and this device is able to produce enough energy to cause alterations down there. So facet joints, they actually cause one kind of pain referral. Nerves cause a pain referral too, and then the deep paraspinal muscles cause another pain referral. So it's all one big mixture of pain that they complain of. So it's typically very orientated to the back and the buttock, hip region, upper thigh area, and the lower back. So you probably know all these referral patterns here, which radiate the same way. If you want to localize the tender tissues, you can palpate the patient sitting or lying face down. It's very, if you palpate on the spinous processes with deep pressure, the patient will indicate where the problem is. And often you're able to reproduce the pain that the patient has by just compressing the joints. This kind of palpation is very efficient if you want to look for disc-orientated pain. You go in between the spinous processes, put both thumbs down, and press deep down in a P2A pattern. That will often reproduce the pain. You have to press hard, and you have to press in the interspinous process space. When you want to treat or differentiate facet joints, you have them sitting, and you put your hand and try and rotate the spinal process, side bend and extend it. That will reproduce the facet pain if that's involved too. Always use two hands when treating. Keep an eye on the patient. Keep an eye on your skin markings so you don't slide off. Stay on the area until the patient tells you that the pain is less. Then you move on. And normally around the spine, I use 300 to 400 to 500 shocks before I move on. And often I only have to treat two segments, L4 and L5, or L3 and L4. It depends on where the pain is. It's often limited to that area. The same in the cervical spine. You're down at C5, 6, 7, where most of the pathology occurs. So in total, you maybe give 1,000 shocks on one side of the spine and 1,000 shocks at the other side of the spine. When you treat pain problems around the spine, you always treat bilaterally. Even though the pain is only at one side of the back, you have to treat the other side because the muscular tension is interacting from side to side and compensating. So if you want to normalize the pain and the muscle response, you have to treat both sides. This is lumbar spine, spinous process lamina down here. You can see we are 4 centimeters down. So use a gel pad 3. With very big men, use a gel pad 4. And again, the same line of drive. Going from the side. I just have a few cases. This was a typical case that we see often. It's a 54-year-old woman. She's had neck pain for a long time, chronically. She's had MRI and X-ray, which shows degeneration of her mid-cervical level. She's received all kinds of therapy and treatment and pain medication, but she still has daily problems. I treated her manually, only a few days relief, and it comes back again. That's a typical presentation of like a degenerative cervical spine. We see there's no normal lordosis. It's totally straight. And we have degeneration, disc degeneration, and osteophytes down here. So this is not optimal loading for the spine, especially not a 6 spine. So we want to alter that. And every time I try to treat this patient and normalize the movement, it holds for a day or two and comes back. So something is not stable there. She had a few treatments, actually 8, and she's now pain-free. And she responded after 2 or 3 treatments, her pain levels were 80% better. That fast. So I didn't generate any alterations on her tissues. I manipulated with her pain perception and the pain-producing structures which are lying around the spine. Here's another one, low back, 30 years old woman, diagnosed with degeneration and protrusion, and had several MRIs and compression of a nerve root actually turned back, but she still had pain. Tried all kinds of therapy, She received 6 treatments and was better, significantly better, at pain level and functional modification. So even though you see structural changes, dyskinesias, osteoarthritis, it doesn't mimic the chance for you to actually make a big change in the pain perception for these patients here. Okay, so now we'll try some practical work. Can I persuade anybody from the audience with a neck pain or low back pain to come up as a guinea pig here? We got one here. Perfect. Excellent. Let's give her a hand.
Because we will use the radio to show the video.
Yep. Perfect.
Here we have a video and record, so you can see treatment in screen.
Okay. If you sit here, what's that way?
If you want to come, you can come.
You can come up here if you want to see.
Yeah.
And help me holding her down. If it's too much one. So let me hear. What's your problem?
Neck, C5,
Yeah.
left,
Okay. Have you had it for a long time?
about a year.
About a year?
Yeah.
Any? Did it happen any certain way or? No. And the pain stays here?
So it's in here and it kind of goes down there.
Down around your shoulder blade?
Yeah.
Have you received treatment on it?
Yes.
No result? A little bit?
Resulting,
But it's still a problem.
we've intensified the treatment, so it's a lot better.
It's better, okay.
Yeah.
So what causes pain right now? What kind of movement or that? So just by letting the patient tell how the patient feels, when she compresses her joints, facet joints, it causes pain in the low side of the cervical region. So I'm just going to have a short feel. Oops. So try and turn your face to next to the right and to the left. Okay. And straight down. And backwards as far as you can. Any uncomfortable? No. So she has I'm just going to feel. So I just feel about how the joints are moving. She's very how the joints are moving. She's very flexible. We'll go back here and press down. Is that uncomfortable?
It starts to get.
I go around the other side. So we compare with the other side. And we just feel over the facet joints how they're moving and rotating. If I turn your head like this and press down. It's a difference from side to side.
Yep.
Yeah, you're lying down on your back here. Face up. Come all the way up here. So we have the patient lying down. They relax the muscles in the neck, so it's even more easy to come in on the joints and actually palpate on the joints. And so I just slide down on the facet joints and feel movement and feel for muscular tension. Any pain in here? Okay, so about C5, 6, I can actually feel on top of the facet joint. You can feel it's a little bit more prominent than the other joints. It's very simple, it's not hard. I compared with the other side. And that's not tender the same way now. So she's had a very localized irritation here at the joints. She has full range of movement, nearly hypermobile. So there's no restriction of movement, but there's pain. And there's no pain into your arms or fingers or anything like that. So you lie face down. I'm just going to open this. So due to the, I'm just going to take a little bit of this. So you want to treat the neck area. I'm just going to take this out too. Sorry. So you want to bring the tissues as close to the surface, so you want to create some kyphosis and flexion of the neck. And then you go in here and you just palpate the spinous processes to get a sense of where you are. And the level we want to treat is down here, just lateral to the spinous process. We find the facet joints which are irritated. This is this level here. And with this young lady, I would use a 2 centimeter gel pad to get down into the structures. So we go here. Down here. Sorry. 20. And there's plenty of gel in here. We use plenty of gel here. And we start around 4 in frequency. We put gel over the skin tissue. So I want to angle in a 45 degree just over the lamina, the transverse process, and the spinous process. So I start with a low dosage, around level 6 here, and I start treating. Do you feel any pain here? No? So I increase the frequency. And if I want to stimulate as much as the nerve tissue, I go for the highest frequency, 8. Any pain here? Then I increase the level, here 6. And normally you have to go up to around 12. Any pain here? Starting? What level? 4, so it's quite low. I'm already on 12 here, which is on the paper is 0.34 millijoules, but it's maybe only half of that down the tissues. So I increase it a little bit more. And what are we on now? 7. I go a little bit down. So. And I hold it here. You tell me when the pain starts getting less. So I'll try and hold it as still as possible. It's down a little bit now. And she's had about 300-400 shots. So I just give it a little bit more. And then I move it down a little bit. 1 second. And in here. Any pain here? What level? 5. Okay, so I hold it here again. When I palpated the patient, it was a very localized area, just one joint. So I'm just working above and beyond that, but below that. Small focal zone. You might have to, when you treated her just in the deep, you might have to treat a little bit more lateral to the muscular attachments there and over the facet joint, which I'll do in just a little while. The pain now, what's it on? 4. Then I just go a little bit lateral. Any pain here? No? And up here? What level? 6. So I'm shooting more straight down to get to the facet joint and the more lateral interspinal muscles. And I hold it here until you tell me that the pain 1200 shots on that side. Then I always treat the contralateral side again at the same levels. Then you came here. What level? So it's less, but I still have to treat it. The spine is a three-dimensional structure, so you'll always have muscular compensations on the other side. Somehow it does a big change neurologically if you treat only one side and two sides. I don't know why, but we find that. So less now. Had already 300 shots here. I move it down a little bit. Anything here? 4. So hold it here again. Until the pain starts dissipating once more. Less now. Not yet. I'm just going to hold it. So it's not very much hard work for me. The machine is doing most of the work, yeah? That's what I like. Yeah. Okay. We've given around 2,000 shocks. It goes that fast when you use a high frequency. I find you get a much larger pain reduction the higher frequency you go.
When the patient says this is
So you deliver more energy to the tissue. And the response different.
When I compress, when we do orthopedic tests, and that's the same in the whole body, the shoulder or the hip, it only gives a fraction of the
So I always have the patient lying in the back again.
So I always try and feel again. So I try to find the same area. This is not altering the tissues. This is resetting muscle tone and neurological feedback from the muscles. And if we can achieve that, the body can start working properly and heal itself up. And no side effects. That's quite smart. Often my patients are in much worse condition. They can't move properly, they can't turn their head at all to one side. And you'll see a much more dramatic relief when you actually start treating them. So any questions to this treatment?
Regarding the frequency, how would you select the frequencies to start? Like, I see you using 8 hertz, right?
Sorry?
The frequency.
Yeah, frequency?
Yep.
Normally, if they're in a lot of pain around the spine, I treat them twice a week for the first to second week. Because I want to change the pain perception and the muscular tension and proprioception. That's often what's causing their persistent chronic pain. So you're not looking for regeneration of the tissues. You're trying to normalize the muscular tension and proprioception and the pain perceivement. And we find if we treat with a higher frequency, we get a better result. What often happens with the patients who's had pain for years is that they guard themselves. And even though after treatment they feel better, they'll start tensing up again just because it's their habit. So you have to break that habit. So you have to be quite aggressive when you start treating them. Sometimes you have some really acute ones, very, very painful ones, which are very spastic and very, very tense. I can even treat them 3 times a week, Monday, Wednesday, and Friday, if they're really bad. Normally that's not the case, but the more aggressive you treat, the faster response you'll get. As I told you here, around the spine, I don't expect to see any tissue changes on the bony surfaces. But what I'll see, when we rescan these patients 3 months afterwards, we'll see this fatty infiltration that will be gone from the spine. And then they can start normal rehabilitation and strengthening exercises because they can move the joints properly. Yes?
You mentioned that that will change the fatty tissue infiltration.
Yes?
How long is it maintain?
We haven't done that yet.
Sessions of
Uh,
whether that depends on age extension.
It does. The patient you saw here, the first one, she was 18 years old, and after 1 month she had massive fatty infiltration. So it does not seem to be age-related when we talk about fatty infiltration. It seems to be movement-related. If there is a lock joint or spasm, then the joints, then the muscle starts to get this fatty infiltration. We've done, after 3 months, we've done control X-rays. We see nearly total reversal of the fatty infiltration. I haven't done follow-up studies since then because it's quite new. And sometimes it's if the patient has no pain, can I kind of justify to take a new MRI scan on this patient here again? But I wish somebody would do some research on it. It would be quite interesting to see if it's going to be permanent. The main focus for me is to get these patients out of pain as fast as possible and keep them out of pain by doing them self-dependent on their own exercises so they can actually continue their improvement.
Does it help the first time?
I don't know. I have no experience in that. Sorry, I don't know. Let me do one more demonstration. Low back pain? Any with low back pain? Because you're sitting so long for today? Any of you have any low back pain? You all healthy specimens? Anyone want to feel the treatment on themselves?
Volunteer.
Yes? Okay.
Thank you. I'm allowed to scream, right?
Yes, you are. You're allowed to swear and scream in my office. So that's right. Do you have any problems at all with your low back?
Every now and then, some discomfort.
And right now, do you have any movements that could cause any discomfort or anything?
I just played badminton last night, so I'm sore.
So you're so Let's try and stand up. Bend forwards as far as you can. Any tension at all? A little bit there? Yes. Then backwards. Any tension there?
I would say yes.
That's right. No. But actually, it has to be a signal. You have to be able to feel it.
Not exactly my region for the first.
Try and side bend. And to the side. Nothing there. Try and sit down here. Just get his face to it. So I'm just going to stress the facet joints. So I'm going to put compression, rotation, extension, and press on the spinal process. Any irritation here? Yes. A little bit. Try and compare to the other side. Rotate, side bend.
Much less.
Not as much rotation. I'm just going to try to do the same here again.
A little bit more.
Yeah. A little bit stiffer. You can feel that. Try like face down from here.
Always. So CIO.
So now we find the lower spinous process here and go into spinal sleep. Hurts there. One level up.
Less. No. Hurts.
Lowest level is a bit fixated in his facet joint on the left side and is a bit more tender. It could be normal after badminton that it's exerted a little bit. We'll try and see if we can cause any immediate reaction by using the shockwave. You can do bets now. You want to? No. And with a gentleman like this, I would use a 3 centimeter gel pad. I'm just going to put some tissue on here. It's very important that you put a lot of gel on. And it's very important that this area underneath the gel pad is fully covered with gel. If there's not enough gel, the shockwave won't actually go through. So the interface has to be all gelled up here. It's very important. So I guess I'll put a little bit more gel on here. And you look into the gel pad. There's not supposed to be any bubbles at all. Then we got thin contact. Important that you position yourself so you sit comfortably. It's a bit hard here. I'm going to squeeze in here. I would normally tissue mark just the area here. So we are going just above the iliac crest and dipping down again. We got the nose into spinous process here, so I'm going to put gel on the side. And as you can see, this area is localized to one segment, the lowest one, the 5S1. Start a little bit low. I'm going to angle the beam a little bit down. You feel the indicating here. Okay, so increase the level here. And the needle in the back. Just localize to the point. Okay. What level are you on? 10 level? 4? Now, 6, so I don't want to turn it up more. When you hit the lower segment, you go at 45 degrees angle, and you go a little bit inferior, because you have to squeeze in between the iliac crest. 8, we'll go a little bit down. What level are you on now? 8. Is it okay? Okay, it's very easy. Okay. You tell me when it starts getting better. We have to be patient. Declining now a little bit. We've got about 500 shots. So when you treat the low lumbar spine, the muscle attachments go more lateral. So you have to angulate it straight down. Don't look at a 45-degree angle. But then they have it down around here. And then you have to get a big spine too. And then we hold it here. On top of it, get into the reduction again. Too much? Okay, 8. Declining. So we're declining again. Takes about 300 to 500 shots normally.
What level are you on now?
I'm at level 14, which is about 0.4 millijoules at skin level, but only half of that at maximum peak level. We're maybe at 0.15 or something millijoules. Then I go to the other side, angle it immediately at the same level. How's the pain over here? 4. 3. getting some increase of pain here. And this is the healthy side. Still the same thing. Declining again. And I'm going to treat the last area just more straight down lateral, so you might feel some more pain.
Yes!
So I'll decrease it. And now? Okay. And declining again. So, we had 800 shots on each side, 1600 shots. Should be sufficient for this year. I'm going to take off this gel again. So I'm going to palpate the same areas. How's it feeling here?
No tenderness.
So I'm pressing quite hard. And I'm pressing interspinously. I'm not pressing over the muscles. But the pain perception has decreased significantly, very fast. That tells me something again. It's a neurological response we're having here at a spinal level. It must be. I can't explain it any other way. So we have you sitting up, please. And try and sit back here on the bench. So I'm just going to try and do the same here.
No pain. No pain. No pain.
It's a very fast response, both in palpations, tenderness, and in muscular tone. Thank you very much.
You're welcome.
So I can't explain it all, but we see some kind of neurological modulation, which actually causes a significant response immediately. And even with very chronic, very, very painful conditions, you'll see that within 2, 3, 4 treatments, a significant reduction. So what I suggest for you, if you have these chronic patients that haven't responded for anything else, try this out. You cannot damage them with this equipment here by these settings I just demonstrated. So it's quite easy. And you have to see some form of relief within the first few treatments. I've had some patients, very bad disc growth patients, chronic ones, they did not respond at all after 2 or 3 treatments. Then it doesn't, in my picture, doesn't help that you continue. There has to be some kind of significant reduction within the first few treatments. Then it's going to be very effective. Any questions to this? Yes?
So what if the patient is having severe pain, like signs of inflammation,
Yes.
acute or chronic, something like acute or chronic? So
Acute onset pain, we try that, so we don't get very good responses on that. It has to be a chronic, neurologically mediated or sensitized pain. Acute chronic inflammations have to be treated conservatively with pain medication, ice, and rest and things like that. That's not an indication for shockwave therapy in my picture.
So if it's acute or chronic, you still need to wait until the
Yes, I would wait.
inflammation.
Yeah. If you have a high inflammatory response, it's a sign that the body is trying to fight something acute off. And the body is working as it should do. And you have to help that pain loss, but not with shockwaves. We don't see the big response there. This is reserved for the chronic conditions.
In the lumbar spine, and your clinic has a flexion extraction table,
Yes?
would you get the client to...
You could do that, yeah? Sometimes when the patient lies down, I put a pillow underneath the stomach so they actually straighten out the curvature. A lot of chronic patients coming in to you with chronic low back pain will have no lumbar lordosis. It will be straightened out because they have so much tension interspinally. So they're lying in the right position. But if you have some more lordosis, you can actually use a table where you can put it in that position, or put a pillow underneath the stomach. That will be easier to get into the tissues.
Now for the positioning, do we have to put the patient prone, or can we sit the patient up and they don't lean forward?
Yeah, I always recommend that you have the patient lying down, especially around the spine, because some of them get very lightheaded, dizzy, and nauseous because you're stimulating so many nerves. I've had several sitting up which actually fainted, so I wouldn't recommend that. Somehow it's also easier for you to treat patients lying down because you can fixate them. They don't move so much lying down. If they sit up, they move. And then they destroy actually what you want to achieve by being at the same spot, the same place. So put them in a position, strap them down, no, don't do that. But have them lying down and put 2 hands on them. You can guide much more. You are more in control. And you won't have any adverse side effects.
My impression was, can we open up the lower spine more if you bend it forward?
You probably can, yeah, but you don't need that because you have the gel pads. So you can actually go into the depth that you want to. As you can see with you, we used a 3 centimeter gel pad that was spot on, and we can even go up to 6 centimeter gel pads. So even with very large persons and with the energy that it delivers, we can actually turn it high enough up to achieve it. My advice is to you, have the patient lying in a comfortable position as possible. Then they can deal better with pain. And they won't slap you on the way out when they pick you up. Any other questions? Otherwise, please take a small break and we're going to...
That's the second half of the
Okay. So thank you for your energy levels here on Friday night. So I'll try and do it quick for you so you can come back home and enjoy a little bit of the weekend. But I'd just like to go into the hip and pelvic area, just clinically to give you some tools to treat the most common pain-producing areas that we see. So we have many definitions of chronic pelvic pain and hip pain. It's an area which is hard to diagnose if you're not very systematic. But first of all, you have to rule out any other pathology to organs, reproductive organs, prostate, bladder, bowel problems. You have to rule them out and use the relevant diagnostic tools to do that. Because a lot of these internal problems can actually masquerade pain in the pelvis and the hip area. Secondly, you have to rule out hip pathology. If there's any swelling in the joint, if there's any degenerative disease, any labral tears, and that's hard to test for, but if you are in doubt, refer for radiological evaluation. We have some deep-seated muscular problems around the pelvis, which can create a lot of problems. They are rare in the deep intrauterine or in the deep pelvic girdle, and they have to be managed by a gynecologist if they actually arise there. And there's a few hints on how these patients actually feel the pain, so you have to refer them if you are suspect of any pathology in these areas. Again, when you have these patients, you have to be very careful about asking them where and how they perceive the pain. Because in the pelvic and hip region, it is very, very narrative about where they perceive the pain, because it's often related to the area of origin. Also, when you do orthopedic tests, it doesn't matter as much as what test it is, it's where the pain is perceived by the patient that's actually indicating where the problem is. So check for lower back involvement by doing a neurological exam and standing exam, active passive motion, straight leg raise. Compress and distract the sacroiliac joints to see if there's any pain there. If you have a true sacroiliac pain syndrome, when you dig your thumb into the sacroiliac joint, it has to be very, very specific and reproduce the pain. Otherwise, it's a misdiagnosed thing. Often, sacroiliac joint problems, if they're there, they're very obvious, and you can palpate deep into the joints and they will complain about the problems. Hip movement is very, very important to rule out pathology, but also to give you a clue about what structure is actually involved here. So you can do the orthopedic tests, which are listed here, but you have to ask the patient where they perceive the pain. I always use X-ray to start with hip pathology or pain patterns, and I often or nearly always ultrasound scan too. MRI is more indicative of other pathologies or deep pathology in the hip joint, labral tears and things like that. So we have to look at the anterior part of the hip and pelvis, the lateral part, and the posterior part. So when we look at the medial anterior part, we have the symphysis pubis, which can be influenced in certain high energy sports like rugby and football, where you can actually have osteolysis and chronic infection of that joint. It responds very slowly to therapy, but shockwave therapy is very efficient in treating these patients here. Injectional therapy does not give the big relief in these areas here. Then you have to palpate the adductor origin, the adductor longus. Strained adductors are very, very often and frequent there. They respond very well to shockwave therapy too. Very easy to palpate. So we start with the symphysis pubis, palpate deeply there, go a little bit lateral, and at the most anterior aspect you will have the adductor longus attachment, and they're very easy to find if you palpate deep there. Then we have the inguinal canal, sportsman hernia. You have to rule that out. Have the patient standing up, palpate the inguinal canal, make them cough, and do the Valsalva maneuver to see if there's any involvement there. They require surgery. Have to sew up the posterior abdominal wall to actually get them better. And then we have what you see most often in the clinic, the iliopsoas. This is probably responsible for most of these chronic pelvic pain patterns. You have some deep-seated trigger points in the upper part of the iliopsoas and at the iliacus at the inside of the pelvic brim. And often you have a tendinopathy of the iliopsoas tendon. It is very hard to palpate the iliopsoas tendon. It lies underneath the pectineus and other muscular structures. It's tightly associated with the femoral vein and artery and nerve, so it's not very reliable to palpate. And it gives you a real deep-seated pain, anterior groin pain, but it can also radiate to the lateral side and the posterior part and down into your thigh. But it's very, very often involved. The problem is that it's hard to palpate. I'll show you how to do it, and I'll show you how to address the iliopsoas in the different levels. You can actually do that with this device here without causing pain or damage to the nerves, vascular bundle, or the hip joint itself. And it's actually the only effective way to treat an iliopsoas tendinopathy. Injectional therapy does not seem to have a long-term relief on those. It's more a frictional problem, which you have to resolve by actually treating the tendon with shockwave therapy. Another thing you have to watch out for, and that we often see, we see small labral tears at the anterior labrum of the hip joint. That's where 90% of all pathology of the hip joint sits. That can cause deep-seated groin pain too. So have to rule that out. If you do ultrasound diagnostics, it's very easy to see. You have to look out for dysplasia and other things, bony structural damages and pathologies down there too. When we go more lateral, we have trochanteric pain syndrome. What does that mean? Can anybody tell me that? That's a big diagnosis of many structures. When we do MRI scans and high resolution ultrasound scan, we see a lot of difficult changes which are very difficult to interpret. So we actually don't really know where the problem is. But mainly, a true bursitis of the trochanter is very, very, very rare. What we thought were bursitis there before is not a bursitis. It's a tendinopathy or frictional syndrome from the iliotibial band. So all the old textbooks which talk about bursitis around the hip, they are very, very rare. And if they're there, they're very easy to see on imaging. Then we have the sacroiliac joint. As I told you, if it's a true sacroiliac joint problem, there will be massive pain when you challenge this area here. Often with trochanter problems, you will have trigger points in the gluteal musculature and the deep piriformis. And you have to go in and palpate the ischial tuberosity to see if there's any tendinopathy at the hamstrings there. Again, true hip pain is very centrally located here in the groin. If you see anything out here, it's more a muscular problem probably. You have just to rule out myalgia peristatica, compression of the lateral superficial femoral nerve, but it's only a sensory loss. It doesn't cause any pain. What we very often see is tendinopathies of the sartorius and rectus femoris, where they attach to the ilium and anterior superior iliac spine, anterior inferior iliac spine, but they're very, very localized and you can palpate them very easily. Also on the lateral side, you have the tractus, which attaches to the pelvic brim. They're very localized and tender on palpation too, and they're very easy to see in ultrasound too. They respond very well to shockwave therapy. So this is the great problem causer in the pelvic region. This area is very hard to get to. It attaches to the medial side of the lumbar vertebrae. It's hard to palpate. You have to go through bowels, and you're very close to big vascular vessels here. So you have to watch out. So it's a specialist condition to treat that with shockwave. I only do it when I ultrasound scan first, so I can see exactly how deep the structures are. You compress the bowels and get them out of the way, and you actually treat the iliosaurus there. It's better to treat them manually. But what you can treat very efficiently, and which is always involved, is the iliacus trigger points. They are actually producing the largest force on the iliosaurus tendon. And that you can get and treat very, very, very well with shockwave. It's very hard to treat manually and do stretching exercises for, and so they're very resistant when you actually try to treat them. And the iliosaurus muscle is the key muscle to normal movement around the low back, pelvis, and hip. So if you can normalize that, most chronic conditions will actually heal up by themselves. But you have to normalize the tension in that muscle. And it's very hard to do that manually. And it's very efficient to do with this device here. Within a few treatments, you can normalize muscle tone totally, so you get rid of irritation around the hip. In nearly all my trochanter pain patients, I find a hypertonic iliosaurus too. And unless you get rid of that hypertonicity, you won't get rid of the trochanteric pain. You can keep on treating trigger points in the gluteus medius and minimus until for days. They'll come back, they'll come back, they'll come back. They are only compensating muscles. So you have to look deeper to the deep stabilizing muscles. And the iliosaurus can cause pain in the back, in the hip, in the groin, into the leg. So it's quite masquerading in many symptoms here again. What you have to watch out for too, of course, is the adductor musculature. You sometimes see them causing groin pain. But most often you have to look at these two muscles. You have to look at the sartorius, which actually arises here from the superior anterior iliac spine. The femoris, which just arises just underneath that from the anterior inferior iliac spine, and the joint capsule. It has two heads, one which actually attaches to the capsule and turns around, and one which attaches to just above the acetabular. Another thing is, what we thought was bursitis of the trochanter is a frictional problem of the iliotibial band going down over the greater trochanter. And when you actually palpate the area, it's sore all over. But when we use Shockwave as a diagnostic tool, you'll find that most of the pain when we treat tendinopathies are actually just underneath the trochanter. And that's where we find some, when we ultrasound scan, we can see small layers of fluid. That's not a bursitis, it's a frictional syndrome, causing irritation to all the tissues, causing the muscles to tense up. So we think they have tendinopathies here, but the problem is actually further down. I've treated hundreds of patients thinking that they had a tendinopathy at the gluteus medius and minimus, but the whole problem was frictional problem down here. And when I addressed that with the Shockwave, I got relief from symptoms. So it can masquerade. Just when we look at the shoulder, the rotator cuff, we see that everybody above the age of 30 will have degenerative changes in the rotator cuff muscles. The gluteus medius and minimus have the same. So even though we see changes in there, they are not always sign of disease. It's just a normal aging process. They are sore there, but the main problem is further down. So just here where they meet, just over the trochanter and inferior, that's where you have the frictional problem. That's why when we put in an injection, steroid injection, just behind the greater trochanter, normally it spreads and goes down and gives good temporary relief, but it comes back again. So you have to stretch the muscles, you have to influence the muscles with Shockwave to get rid of the chronic problem. You can keep on treating these trigger points, as I told you. You can also treat trigger points in the infraspinatus and teres minor. They are always there if you have a shoulder problem, but they're not the cause of the problem. So when we palpate, it's the key to the right diagnosis. So you have to create or mimic the pain that the patient has. If it's a true tendinopathy, you have to palpate the anterior facet of the trochanter where the gluteus minimus attaches, or the lateral and superior lateral aspect of the trochanter where the gluteus medius attaches. They have to be marked painful there, and it has to reproduce the pain when you press hard in on them. If it's just a vague pain, go distal, go just over the greater trochanter and inferior. And if you put in a hard pressure with two thumbs, if that reproduces the pain, that's where you have a frictional problem instead. And that's where Shockwave therapy can actually tell you the whole story. Because if you put it on the tendon attachments and it only causes mild pain, it's probably not the problem. If you put it further down and it reproduces all the pain and the thigh pain and everything, you're on the right spot. So use it as a diagnostic tool too. So I'm just going to skip all these here and trigger point programs here. So palpate. Palpate, palpate, palpate. Oops, sorry. So in the line of what you see most often, we see these here. And with this we also see the frictional syndrome of the tractus iliotibialis. Again, we work quite deep. If we do a tendinopathy of the iliopsoas, it's 3 to 5 centimeters down where you have to hit them. You have to position the patient quite carefully, and if possible, do some ultrasound diagnostics before you go into it, just to make sure you're on the right spot. If you want to treat the tendons around the gluteus medius and minimus, you have the patient sideline with the leg slightly flexed 45 degrees and adducted, so you bring up the tendons so you can get down into them and stretch them out. If you have the tensor fascia lata attachment where you have the problem, you have them lying in the same position but with extension and adduction instead, so you bring up the tendon here. The adductor longus, we do that in frog leg lying position, 45 degrees flexion and Faber position here again, and you go into the bony attachment. It's just in the bony attachment to the joint. The tendon is not very long. very, very short, so you're going to the bony attachment to get the right result there. The iliopsoas lies a little bit more lateral, just inferior to the inguinal ligament. If you want to get to it without getting into the vascular bundle, you have to have the patient lying in the same position here. Then the nerves and arteries are going to lie medially, and the tendon of the iliopsoas will lie just in the middle, and there will be no structures which you don't want to affect lying on top of it. Here we see an ultrasound of the greater trochanter. This is the gluteus medius tendon coming down. We see some calcifications in here, and it's swollen. Here we see a partial rupture, where the tendon has actually gone loose. In the normal population, when you're 60 years old, you will have a complete rupture of one or two of the gluteal muscles. And they're pain-free. Just like the supraspinatus, above 60 years old, about 50% will be ruptured due to wear and tear, but no pain. So be careful about what you conclude when you see a picture like this. You have to rely on your palpation. Often when you take an x-ray, you will see some calcification lying over the greater trochanter, but it doesn't have to imply that there's anything wrong. This is an ultrasound scan of the head of the femur. This is the acetabulum up here. This is the anterior labrum. Normally it should be very fine and nicely outlined. This is a tear of the anterior labrum. It's an intra-articular problem, so I can keep on treating the muscles around here. They need some surgery on that problem instead. And when you see a structure like that and you follow down the femoral neck here, you see a lot of fluid lying down here. That's intra-articular fluid in the joint. So we have a problem inside the joint, which is mimicking pain from the muscles. This is a transverse view. This is the femoral head here, the pectineal ridge here. This is the femoral vein, artery and nerve. And here's the iliopsoas. Psoas muscle, iliacus coming out here. It's very big and thickened. That's how a true iliopsoas tendinopathy looks like on an ultrasound scan. This is seen a longitudinal view. This is the iliopsoas tendon here. This is fluid down here during the femoral neck, so you have a large bursitis under the iliopsoas. What happens when you get an iliopsoas tendinopathy is that it thickens and it starts grinding over the hip joint and irritating the structures. So it creates a frictional problem, just like the frictional problem over the trochanter. It's not a true bursitis, it's due to a thickened iliopsoas tendon. Sometimes they can do exercises and get to it, but if it's firstly it's thickened, it's very hard to normalize, and that's where shockwaves come in again, where you can actually treat them. So, let me just show you how to treat the most often involved muscle, the iliopsoas. Even though you have pathology in the surrounding structures, if you don't normalize that muscle effectively, you won't get a good clinical and fast result here again. So there's a few ways to get to it here. So does anybody suffer from hip pain? Yes? Excellent. Can you come up here, sir? Okay. How long have you had hip pain for?
A couple of years.
Couple of years.
Yeah.
And where does the pain stay? Right back there?
Yeah.
Okay. And when do you feel the pain?
When I run for about 20 minutes.
After running? Okay. And does it radiate any other where?
What has to do with the structures there? Okay. If I can have you lying down.
Face down or face up?
Face up, please. Face up. So we just do some raising of our arm.
Hurts now.
It hurts now. Okay, straight leg raise hurts in the buttock.
Yeah.
Yeah. So we flex the neck. Any pain here? A little bit. We internally rotate it quite a lot. Anything here?
Mm-hmm.
Also in the buttock?
Yeah.
Externally rotate. Any pain there? Also in the buttock? So what I always do is to rule out internal hip pathology. You do the compression test, the failure test, scar test, you know these yet? So you go in here, internally rotate it, and you squeeze the joint here. Any pain in here? Also in the buttock?
Yeah.
Okay, if you had pain in the groin, it's normally a hip pathology, but it refers pain into the buttock. So what do I do with all these movements here? I'm stretching the muscular tissue also when I'm doing that, and that creates pain here in the buttock here. We take the leg out here. So we go in, we find the inguinal ligament, anterior superior leg spine, the pubic symphysis, and I palpate over the inguinal ligament. Any pain here? No. If you find the inguinal ligament and you want to see if there's any involvement of the distal iliopsoas tendon, you go down where the rectus femoris hits the obliques from a straight line down. It hits actually the inguinal ligament on the middle. If you go 2 finger breadths, 3 finger breadths distal, you're just on top of the iliopsoas tendon. It lies underneath. If you palpate medially, you can feel the pulse from the femoral artery. Then you're too much medially, you just fall off, and it's just when you go off the artery and you press down here, any tenderness or pain here. Try and lift your leg up a little bit against me, and down again, and up, and down. When the patient does that, you can feel the tendon actually rolling underneath your fingers, then you know in your right spot. So it's only about 1 centimeter or half a centimeter more lateral to the femoral artery that you'll find the distal iliopsoas tendon. We straighten out the leg again here. Make it flex and relax your leg out towards me. We find the umbilicus. You go lateral into the junction between the rectus abdominis and the obliques, and you press and you relax your leg. And you press medially. And deep down here, you have to go quite far down. It's quite uncomfortable. Right here, I'm on top of the iliopsoas muscle, where it actually comes out from the lumbar spine. If I palpate deep, I can actually feel the transverse processes. But you have to go deep, and you have to go slowly, and you have to relax your leg. It's not very comfortable. So I'm just going to have a feel about how much tension there's on this muscle. I go a little bit distal, further down to feel the muscle. And already here at the brim of the iliac spine, the muscles from the iliacus conjoin and convene. And that actually makes up 2/3 of the muscle. That's iliacus. It's hard to get into here. So what I want the patient to do is slide on your right side. Follow down. Slight flexion of both legs. So if you go inside. What happens when I do this is all the bowel content will actually go medially. Then I find the iliac crest here. And when you go deep here, you will actually be able to palpate the iliacus lying in here. And that's the key to treating the iliacus too. If you're in doubt and you haven't got an ultrasound scanner, it's actually go in and treat the patient's sideline. Because all the structures will actually, bowel content and arterial structures will go medially, so you will have them out of the picture. So you go in here and take a deep palpation, and you feel on the muscular tissues here. Because it's uncomfortable to palpate, just by pressing into the muscle and the patient feels pain, it's not enough. So what we do is actually we're going to use this Shockwave here as a diagnostic tool to see if when we actually hit the muscle, where does the pain radiate to. If it reproduces the pain, it might be one of the areas that we have to look for. Lie face down. So we feel over the sacroiliac joints, and they're quite easy to palpate. You can slide your fingers in there, and you press deep into them. Any pain here? Both sides. Right side. You can spring them and see if they feel the same. Yep. Any pain here?
Yep.
Okay. So I lift up the leg, and I make the body relax, and I press over the sacroiliac joint here. Any pain here? There's a little bit of fixation in that joint. So I go lateral into the muscles here. And we go into the gluteus medius. How does it feel here?
Okay. No pain.
And in here,
A little bit.
down here,
Uncomfortable.
uncomfortable. We go over the grade of the cancer. So I start at the top anterior
Yes.
part, painful here,
Yep.
and the lateral part, painful here,
Mm-hmm.
and the posterior superior part, painful here.
Yep.
I go further down lateral on the grade of the cancer and press over just the lateral part. Any pain here?
A little bit.
I go just underneath the grade of the cancer to look at the iliotibial band friction problem. Any pain here?
Yep. Great pain. Head.
Most pain here.
Mm-hmm.
I'm actually over the iliotibial band. That's producing most of the pain right now, but it's still unspecific here because I'm only palpating. We're just going to look at the pelvic positioning. So we look at leg length discrepancies. There's nothing there to start with.
Head.
Go on the lumbar spine.
Mm-hmm. Head.
And if I press here, there's local pain,
Very painful.
just locally.
Mm-hmm.
Okay. A lot of compensations around this area here. Most likely we have some insertional irritation here because it's a little bit painful. Most of the pain lies just inferior to the grade of the cancer. So we'll try and see if we can treat all these structures to start with. Not much trigger points in the gluteus medius and minimus, doesn't look that way. But compensation in the sacroiliac joint and the low lumbar spine. What muscle actually attaches or crosses all these joints? Iliopsoas. So, what the iliopsoas always will do if you have pelvic problems, it's going to try and protect the area by tensing up, and you'll get a lot of compensations. In the low back, sacroiliac joint, muscular attachments. So we have to find out what's actually the real problem here. So what I do always is that I try to treat the most painful aspect of the pain that patients feel like, and that seems to be the tibial tract friction system, and then try to normalize the iliopsoas tone. Often when you normalize the iliopsoas tone, the back problem and the sacroiliac joint irritation will go away because it's a compensation. So can I have a line here on the side, left side, with the back here up? Can you line? Okay. So a back hip up, all the way. That's more comfortable there. So we line the side here, all the way around. So normally I would have a little cushion in here, so we don't push too much inside. We take down. Here we have the iliac crest. When we palpate down, it's quite easy. Yes. You can feel the trochanter quite easily coming up here. I'm going to do some palpation again. Pain here, pain here, pain down here. So it's just inferior to the process here. It's the trochanter spine. Because it's such a big area, I don't want to spend the whole day treating all these structures. I'm going to use my shotgun, which is a linear device. Because these structures are about 2 to 3 centimeters down, and I can run down here, take the insertional attachments, I can take the tibial band with one shot. It's 5 centimeters wide, it's very, very deep, and this area is very, very tender. It doesn't need as high a dose as the other areas. With this one here, we have a 20 millimeter gel pad. When I run it down here, I'll take all attachment sites around the trochanter and I'll treat the tibial band too. So you'll save a lot of time. So we start here. We're going to squeeze in here. So most important thing is that the therapist sits comfortable. And right here, I start with the low dose. And then I start just above the greater trochanter. Can you feel any pain here? I increase the frequency. And I increase the any pain here. Okay. Then I go distally. Pain here. Tiny little bit. More distally. I'm just lateral to the greater trochanter now. Any pain here? No. Little bit. And here. Okay. Just a little bit so I increase the dosage. Any pain here? Look it on here. A little bit. What level? Tiny. So I'll go a bit further up here. What level around now? 0 to 10, what did you say? 4. I go up again. And what about now? 5. Okay. So we're actually just below the attachment. We are more over the greater trochanter. There's still tenderness in the muscle attachments. That's probably due to increased tension in the muscle. There's no pathology in the tendons. If there would have been a tendinopathy in the gluteus medius minimus, it would be flying up in the ceiling here. That's very, very painful. So I give it about 300 shots. I move it down half a centimeter. How does it feel here? 7. This is more the tibial tract. It's a frictional problem. And what does frictional problem indicate? They indicate there's some biomechanical disorder here. So there's increased tension on the muscle flow here. What muscle can alter the position of the hip joint? Iliopsoas and the great and the lateral rotators can also do that. But always treat the deep muscles first, and then the superficial afterwards. I'm going to go 5 millimeters down here. Right down here. Sorry? 5 millimeters, I move it. Yeah, I use full dose here. If there would have been a tendinopathy, I would not have been able to turn it up that much. So this here is more a mechanical irritation, where I just want to remove some of the irritation and the pain. So I treat this fast first. And I move it down a little bit here. And now we're just on the bottom part of the greater trochanter, and that's actually the most painful area. Yeah. We're just going to give that about 300 shots again. So it's referred pain down into the thigh. And I'm moving it once more. Stronger. And now we're just below the greater trochanter. So it's the iliotibial tract converging with the gluteus maximus and the tensor fascia lata. We have a very tight band here, so if they tense up due to hip biomechanics, it will increase the friction over the greater trochanter. And that's what we see in practice. It's not a tendinopathy. Most often it's the iliotibial tract. And that's where you find the small fluid layers, which we thought were bursitis. They're actually just a frictional irritation. And I'm going to move once more down here. About the same. This device is very easy to hold. It lies flat in a big area, so you don't have to hold on to it with both hands. So I'm just going to give that 300 shots too. Perfect.
So let's see. This area here. And then we have you lying on your back. On your back, face up, please. So now we're going and try to see if we can find any pathology in the iliopsoas. So we flex the leg here. Find the inguinal ligament. I would actually like you just to. Can you take the top?
Sure.
Positive shows down. And what we do here is we actually address it from underneath. Start with. So we just make a leg out like this and let it fall out. Basically. So yeah. So that's it. I'm just going to come in here. Here we have the inguinal ligament. Here we have the attachment. So right down here, the straight angle, that far down we will actually have the psoas tendon. So I palpate here. And here I can feel the pulse from the femoral artery. And I go a little bit lateral to that. That's where we have to use the device here. Change. You're a 40 man, I can see. So we're going to address the psoas tendon and the muscular tendinous area too. Turn around here. So a lot of the energy is going to disperse, so we have to use higher energy levels. We're going quite deep. And I'm coming in here. And we start here. Do you feel any pain here? No. I increase the dosage. And I have to search. Anything in here? Nope. No pain response. I'm just above the iliopsoas tendon and above the joint too. So we can rule out that there's a tendon problem down there. Otherwise, it would be very, very painful. So we turn you off the gel here. And then I would like to have you sideline towards me. So we go into the iliacus muscle. So I go find the pelvic rim, and you come a little bit further away. So this way, yeah. Okay, so. And you line it back again. And you let your leg fall right here. So I'm going to take the anterior approach here. Patient lies a little bit more relaxed in that position. So I'm going to try and see if I can find any trigger points in the lower part of the psoas and the iliacus. So here's the anterior, this is the pelvic rim, pelvic spine here. So I go in here. I angle it a little bit straight down and laterally. And we look in here. Any pain there? It doesn't seem to at all to be involved right now.
So this way you can actually rule out which kind of pathology there is. Even though if I ultrasound scan it, it wouldn't give me the whole truth. I have to see if I can reproduce the pain that the patient has. So, what we have here is still some pain up here. Nope. In here.
Nope.
Not really.
It's around my L4.
Yeah. I'm just going to bring it. Any pain here?
Can't even.
Not really.
Yeah, painful here.
And there's a little spinal problem up here too. I would adjust that and treat that too, if I could do that. So, while we have the patient here, we might as well go in here and treat it with a shockwave. And a 4 millimeter would probably be good here. So I start down here, just at the L4-5 level. You feel any pain here? So increase the frequency. Any pain in here? Nope. Here? So increase the intensity. A little bit here? How much?
Very little.
Gonna go up here. There? Okay. And how much is the pain level on here?
2.
2. Very low. I increase it a little bit. And I just hold it here for a little while. I'm just anchoring at 45 degrees to the level here. And then we're going to go straight down here. Any pain here?
Nope. Yeah.
The patient knows his pain. He says L4. He's right. So how bad is the pain here?
Not much now. Further down again.
Okay. It goes down pretty fast. I'm at least going to give it 300 shots. I'm just going to go a little bit further up here. Any pain here?
Not much. Just irritating.
So I just treat the joint above and below. I'm just going to return to L4. 5, that's where he has most of the problems, so I'm just going to hold here and give him 300 shots more.
There's no pain to feel so.
Okay. Perfect. I'm just going to adjust the other side too. So we treat the other level here.
Yes.
Got it now?
Yeah. About 5.
So treat both sides, normalize muscle tone. So it looks like this patient has a biomechanical problem. He has got some compensations in his low back, in the pelvis, and the musculature around it. And also it only comes after 20 minutes of running. So I'll probably describe some stretching and strengthening exercises for his muscles surrounding the hip to normalize the biomechanics. And here, I'm just going to go a little bit lateral to get the other muscles around the same level here. And a little bit more. one advantage is that if you can use a high frequency, the treatment time actually goes much faster. So it's not so bad. We'll just go in here and clean up our mess. So I'm just going to come in here. How's the feeling here?
Yeah.
There's still some increased tension here, so it's a long-standing problem where he has actually some muscle guidance, but it's not a localized injury here. It's more like in my aspect, I think it's more a compensation where he's trying to tense up in his right side of the spine to relieve the tension on his hip here. You can stand up for me, please. So the hip is a very complex area. And orthopedic tests, muscle tests, and palpation is not always valuable. So you have to use this as an extra diagnostic tool to actually guide your way into where the problem is here. Okay. So, yes, thank you very much for your help. Is that if you have a problem, it's going to be very, very well defined and declared when you put Shockwave on it. If we have a patient like this, with a more biomechanical problem, we'll
have another setting of it. But if we use the Shockwave device as a diagnostic tool, it will actually guide you to what kind of direction and treatment that the patient needs. Any questions? Yes? On a woman, normally for a hip problem is about 30 millimeters for the iliopsoas tendon. That fits with most women. With the men is 40 or sometimes 50 millimeters, depending on how big they are. Anyway, if you choose a gel pad, and if you're sure about the diagnosis, and there's no response, and you're not that used to it, try and use a deeper or more shallow gel pad to see if you're on the right track or not. When we use the gel pads here in these levels and these high energy levels, the focal zone of the beam diminishes, so you have to be quite precise. I'm very good at looking at people now, how big and short they are, but still, in the old days, I tried a bigger and a smaller gel pad to see if I can get any response. And if I still didn't get any response, then I was sure it was on the wrong place. If you go too deep, you're just going to address other structures. If you go deeper, because the iliopsoas tendon is lying just on top of the joint, hip joint, you actually go into the hip joint. So if you have any labral tears or irritation of the hip capsule or anything like that, you might provoke pain that way. Some people who have osteoarthritis of the hip joint, they have small osteophytes and cartilage problems. If you hit that with a Shockwave, it'll cause pain too. But it will cause a deep localized pain in the groin area. So be sure that you rule out the two things here. Better to go shallow. Always start shallow if in doubt and then go deeper. Also the same around the spine. Nothing will happen if you just hit the nerve root as long as you take it away again. Don't sit there 10 minutes and hit the nerve root. That might be not a good idea and you won't be allowed to do that. But nothing happens with these doses here. So, with these doses we use here in living tissue, human tissue, you can only cause some adverse short-term effects as long as you just adjust your treatment to it. So watch out for the big vessels and big nerves. If you put it over the sciatic nerve, it will radiate all the way down into the foot. And if you put it over the median nerve, it will radiate into your fingers. So they are quite sensitive to big nerves. Small nerves are not sensitive to Shockwave. Any other questions, ladies and gentlemen? Yes? Sorry?
Apart from ITV, where will you choose the linear prop to treat the patient?
Sorry, once again.
The linear
yes?
prop, where will you use that?
I always use the linear device with more superficial structures. If you have, let's say, a shoulder, we know that the deep structures are rarely more than 20 millimeters further down, even with a big guy. The tendons of the biceps longus and the supraspinatus, infraspinatus, subscapularis are quite superficial if you put them in the right position. And often when you have a shoulder problem, we have a diagnosis called impingement, don't you? What is impingement? Is it a very precise diagnosis? No, it just says that something is hurting when we actually compressing the joint surfaces upon the tendons and the bursae. And what you see very often is that if you examine a chronic shoulder patient, most of orthopedic tests will be positive. Isn't that true? Many orthopedic tests are positive. So it's very hard to make an exact diagnosis. This is a supraspinatus tendinopathy. It's very hard to do that orthopedically. And what you find most often when you ultrasound scan is that if you have one lesion, for example, in the biceps, long head of the biceps, it's a supraspinatus, it will always affect the tendons nearby them. Long-standing inflammation will affect the tendon sheaths and the adjacent tendons. And we know that the supraspinatus and infraspinatus, if you look at them, they're actually, you cannot see the difference. They actually are one homogeneous structure when they insert into the tendon attachment. And the biceps tendon and the subscapularis are interacted by the coracohumeral ligament and the superior glenohumeral ligament. They actually lie as a sheet around them. So if you have long-standing inflammation in one of the tendons, it will affect the other ones. It will create small adhesions. You can actually see that on high-end ultrasound. You can see small crystal formations, which are sign of a chronic inflammation. And if you don't treat all parameters, you won't be successful. So I always start with the linea on the shoulder, and I treat, if I find mainly a supraspinatus tendinopathy, I put the linea on. It's 5 centimeters wide, so I can treat the biceps, long head of the biceps, the tendon sheath, the supraspinatus and the infraspinatus in one go. I can treat the whole area, and I can go up and treat the bursae walls too if they're affected. So I always do that. The first few times I use the linea to the more complex areas, also the hip, where we have multiple attachments, and that gives a much better clinical result. When the pain dissipates and gets more localized, I take the other headpiece and finish the treatment on the areas which are still producing pain. So it speeds up, the linear device speeds up your treatment very much, I must say. Also at the Achilles tendon, instead of going all the way down on a largely chronically inflamed tendon, I put the linear device on, so I only have to treat 1 or 2 places and give it a lot of energy that way. Also, we see with the patellar tendon and the Achilles tendon, we see a lot of reaction in the fat pads underneath. That's where you actually have the ingrowth of these nerve vessels which are producing the chronic pain. And due to the large field of focal zone, you treat the fat pad, the ingrowth of the tendon, of the fibers, and the tendon itself. So you have a 2 centimeter focal zone. So you can treat all structures in one go. And the funny thing is about chronic tendinopathy of the patellar tendon and the Achilles tendon, most of the pain is coming from the fat pads. That's where the ingrowth of these nerve fibers come from. That's why they had great result in actually putting an injection with saline, 50 milliliters of saline, in between the peritendon and the fat pad. After one treatment, they were 90% pain-free because they broke all this ingrowth from these nerve vessels. They were sore, but they were pain-free. The problem is if you do a high-volume injection is that you can cause some neuropathy, you can cause some sensory loss, and you cause some damage to the tendon sometimes. So try out with the shockwaves first. If that doesn't work, you can go on to more aggressive therapies to solve the problem. Yes?
If there's a partial tear,
Yes.
are you going to use the Shockwave?
In practice, we see if you have a partial tear more than 30% of the tendon, you should refer for surgery. They don't respond well. And if the tendon is of good quality, of course. If you have a 60-year-old man, it's not always the tendon is good enough quality so you can actually do surgery on it. But I would recommend not to treat large partial tears. Not because I think that the shockwave is going to do anything, but I don't think if you have a partial tear and you have retraction of the tendon, there's no tissue to actually go in and touch each other. You have to have a relatively intact tendon before you have full success with the shockwave therapy. Small partial tears heal up well, but larger partial tears you should recommend or refer to an orthopedic surgeon to look at it first. What you see sometimes with a large tear of the Achilles tendon, if you try treating them, they might rupture fully anyway. They're not stable. So large partial tears, refer for surgical evaluation. I would always do that. It's been a long evening, hasn't it? If there's no more questions, I will let you off now, and thank you very much for your participation today. It's been a pleasure.